So this is pretty interesting here, and I know there's a lot of colors going on here, but hang with me. And there's also a QR code for this second research study that's in green. If you want to scan it and read it, it's pretty interesting. So the AHA, the American Heart Association, recommends that we withhold nitrates in the presence of a right ventricular myocardial infarction, and that is in both the 2015 and the 2020 guidelines. So that recommendation is based off a 1989 study of 40 patients. The dose of nitro was not captured in that study. So it could have been the correct dose, or it may not have been. And the routes were varied between sublingual, IV, PO, and transdermal. So in those 40 patients who were given an unknown dose of nitro via several different routes, 40% of those patients had adverse effects. And what they defined an adverse effect was a decrease of 30 millimeters of mercury or more in the patient's systolic blood pressure. So 40% of patients had adverse effects from that 1989 study. That is the reason that in 2024 now, we are continuing to operate and practice as if we should never, absolutely never give nitro to a right ventricular wall in my patient. And I've taught it that way for years. And I've tried to beat that in the heads of my students for years because they're going to see it in the field. They're going to see it on the national registry, right? And that's what AHA is telling us to do. So in 2023, Wilkinson, Stokes, Betson, and Sawyer, they did a meta-analysis, which is basically just a review of another research study. And that study was in 2017 of 46 patients. Nitro administered to inferior and right ventricular MI patients is more likely to cause an adverse effect, but it's statistically insignificant when compared to other cardiac regions. So what that means is, yeah, if we give nitro to a patient who has both an inferior and a right ventricular wall MI, they're a little bit more likely to have an adverse effect, but there's really not that great of a difference in the adverse effect or the rate of adverse effects those patients are going to see versus the adverse effect that my septal wall in my patient might have from nitro, or my anterior wall or my lateral wall in my patient might have from nitro. So something that all of these studies pointed out is nitro has a serum half-life of approximately 3 minutes. So you'll see some variation there of like 1 to 4 minutes, which is why we say we give it every 5. So it has a serum half-life of approximately 3 minutes. So if a patient does have an adverse effect, if they do become hypotensive or they do become a little bit bradycardic, it's likely to be pretty transient. It's likely to last just a few minutes before that half-life of nitro is gone. So what that 2017 study classified as an adverse effect was a heart rate less than 60, a systolic blood pressure of less than 100, or a drop of 1/3, so a systolic blood pressure drop of 1/3 of its initial value, a GCS decrease of more than 2 points, syncope, arrest, or death. So this study in 1989 of 40 patients just classified an adverse effect of a decrease of 30 or more millimeters of mercury in the systolic blood pressure. This 2017 study actually looped in a lot more signs and symptoms to be an adverse effect in their study, which is good because it kind of further enhanced the point that nitro can cause adverse effects, but it doesn't really cause any more adverse effects in that inferior RV wall in my patient than it does in any other cardiac region. So that doesn't mean to go ahead and start blasting everybody with nitroglycerin who's having a right-sided MI. You obviously still have to go off protocols. You have to go off your medical director's guidance. But really the whole point of me telling you this is I do think that we will see, I don't know if it'll be the next AHA update, but I do think this could change from the AHA recommendation. And I think this could change from a local protocol standpoint, that we may no longer be told to withhold nitrates from that inferior and right-sided MI patient, that as long as we have an IV in place and we have fluids ready, the benefit of nitro far outweighs the possible adverse effects that they could have. So another really interesting thing here was from these studies were that Nitro administered to isolated inferior wall MIs, so just elevation in 2-3 and AVF, the right side was fine, had the lowest number of adverse effects. So I think that's important to call out because, if you ask, in your firehouse now, there's probably some people that are under the impression that if they have an inferior wall MI, I am just period not giving Nitro because of the fear or the worry with that right-sided involvement. What these studies found was inferior wall MIs alone, isolated inferior wall MIs, so that occlusions down the posterior descending artery, those types of MIs actually do the best with Nitro. So the patients who actually will benefit the greatest and have the lowest number of adverse effects from nitroglycerin, sometimes those patients don't get it at all because of a fear of right-sided involvement. So it's definitely something to keep in mind and think about as we start to see these patients in the field. So again, that QR code's there. You can scan it and it'll take you to this meta-analysis here. I can also send it out if you'd like me to. Just reach out afterwards and I'd be happy to provide it.